Over the past few decades, real-time ultrasound guidance has raised the standard of care in anesthesia for numerous procedures, including vascular access and peripheral nerve blocks. Neuraxial procedures such as labor epidurals are still largely performed without ultrasound guidance. We have developed a patent-pending device, the biplane, which aims to facilitate real-time ultrasound guidance for neuraxial procedures. The device includes a sterile, single-use rigid sheath that holds an existing commercial ultrasound probe. The device allows the practitioner to anchor the ultrasound probe to the patient's back and make the necessary targeting maneuvers such that the integrated needle guide targets the appropriate structure. The device will be priced in the range of $20 to $40, similar to the disposable costs for video laryngoscopy. The market is large, with millions of procedures performed every year in the United States that could benefit from the biplane device. Here we demonstrate how the biplane device facilitates epidural access using a spine phantom. After a sterile field is established, the ultrasound probe is loaded into the single-use sterile biplane device. The device is centered on the patient's back with the probe in the transverse view. The adhesive backing is removed from the frame anchoring the device to the patient. In this demonstration, the device is held against the phantom with white straps. The depth of the ligament is measured, either visually, with caliper software on the ultrasound machine, or in future implementations by a machine learning algorithm. This line is an artifact left by previous needle passes through the phantom. The device will be suitable for epidural depth ranging between 4 centimeters and 15 centimeters. The probe is rotated to a modified parasagittal oblique view. This view is characterized by a 15-degree tilt in the medial and cephalad directions. This orientation of the probe is chosen to maximize the size of the window between the bony obstructions. Given the depth of the ligament, we know how far laterally the probe must be translated so that the needle guide axis intersects the target. Next, the probe is moved in the vertical direction so that the midline of the probe view passes between adjacent lamina. Finally, the needle is advanced through the needle guide with the usual loss of resistance method used to detect epidural access. Targeting can be confirmed at this point by injecting saline and seeing the ligament separate from the dura.